Good afternoon, everyone. Welcome to the Canadian Breast Cancer Network's webinar for this afternoon. We'll just give everyone a minute or so to come into the virtual space, make sure your tech is working. Hopefully you can hear me as well as see me. And again, if you're just joining us, welcome to the Canadian Breast Cancer Network's webinar this afternoon. I see that there's still people joining. We have a good sized group this afternoon, so looking forward to our presentation and to taking some of your questions throughout the session. Again, welcome everyone. We're just giving everyone a minute to join us in the virtual space. Make sure that your audio is working. Hopefully you can see me and hear me. It looks like the number of participants is slowing down. So I think at this point we have everyone who was in the waiting room, and I'm sure we'll have a couple more joining us throughout the session. But maybe what we'll do, since we don't want to take up too much time with the intros and whatnot, we want to get to our actual session today. Maybe we'll start things off. So thank you again, everyone, for joining the Canadian Breast Cancer Network for today's session. We'd like to welcome you. Again, hopefully you can hear me as I'm speaking. If you are having any technical difficulties, please feel free to type into the chat. I'm Jen Gordon. I'm the Director of Operations with the Canadian Breast Cancer Network. Just before we begin and before I turn it over to our host, just wanted to run through a couple housekeeping items for today. So we are recording this session, which is great news. In case you know anyone who's missed this, they'll be able to view the on-demand recorded version on the CBCN website. So it's cbcn.ca, and I will be typing the link into the chat in just a little bit. It's usually up within a couple of days. There's also other pre-recorded webinars available at that same link. So please take some time to go through those. We will be hearing from our expert speaker for the first part of the session, and then we will be taking questions at the end. So please feel free to submit your questions throughout the presentation. You can do so using the Q&A icon. Usually it's somewhere around the bottom of your screen or maybe towards the side. If you can't find that, you can submit them through the chat as well, and we will get to as many of the questions as we can at the end of the session. I'd like to extend a sincere thank you and appreciation to our sponsors for today. So Viatris, our gold level sponsor, Novartis and Merck, who are silver level sponsors, and our bronze sponsors, AstraZeneca and Pfizer Oncology. And so without further ado, I'd like to welcome the host for today, Kathy Amandalea, who is the chair of the board of the Canadian Breast Cancer Network and has been with our organization for over a decade now. And having had the lived experience of a breast cancer diagnosis, Kathy really understands how important these new and innovative therapies and research is to patients. So Kathy, turn it over to you. Thank you.
Thank you, Jen. Thank you, everyone. Welcome again to everyone. And thank you for joining us today. I'm very pleased to welcome Dr. Alyssa Vito, our expert speaker for this session. Dr. Vito obtained her Bachelor of Science in Biochemistry from Eastern Michigan University. At the age of 23, while living in Toronto, she was diagnosed with stage 2 triple-negative breast cancer. After completing treatment, Dr. Vito decided to switch her career path and go to graduate school to study cancer research. In 2015, she completed her Master of Science at McMaster University, focused on the development of molecular imaging probes for breast cancer. She then pursued her PhD, also at McMaster University, focused on novel immunotherapies for triple-negative breast cancer. Dr. Vito is now working as a senior scientist for a biotech company based out of Toronto. Her work focuses on the development of radioligand therapies for cancer and combining these with immunotherapies in clinical trials. Dr. Vito, welcome. Thank you for joining us. It's a pleasure to have you here today.
Thanks, Kathy. So as Kathy and Jen said, today I'm going to be talking to you guys a little bit about my own experience, and also we're going to take a deep dive into immunotherapy. So first, I'm going to tell you a little bit about kind of the intimate way that cancer has infiltrated every aspect of my own life and where that has really led me to both personally and professionally today. And then, like I said, we'll take a deep dive into cancer immunotherapy. So really what it is, how it works, and what it really means for breast cancer patients and the breast cancer community. So I grew up with a mom who owned a fitness center in a tiny little town where I grew up. And so I basically grew up doing fitness classes and every sport I could imagine. I was really healthy as a kid. I really, by the time I entered high school, was just like a full-blown jock and totally obsessed with sports. So in high school, I decided to really focus in on field hockey and rowing as my two main sports. So I would wake up at 4 a.m. every morning and go to my rowing club to row before school, and then finish my days at, about 7 or 8 o'clock p.m. on the field hockey pitch after school. I was also really lucky during my time in high school to have a very exceptional chemistry teacher who had really pushed me and nurtured me to kind of, explore my scientific curiosity and really develop my opinions about the real world implications of science and chemistry in general. And this was really crucial in my development and in choosing my career path moving forward. So I started volunteering with the Canadian Cancer Society, I think when I was about 12 or 13. I actually didn't have any personal ties to cancer at that time, but I was just always very fascinated by the disease. And so, initially I started with events like, Relay for Life and Daffodil Month and things like that. And I was fortunate enough that I was coaching a Paralympian rower during high school, and her husband was actually very good friends with the chief radiation oncologist at Credit Valley Hospital. And she knew that I was really involved in cancer already. And so she offered to introduce me to him. So I met with Tom probably when I was 14, and he instantly became like a mentor to me. So I would meet with him and we would just have lunch and chat, and I would just ask him endless questions about cancer and oncology and a career in the field. He also introduced me to the volunteer coordinator at Credit Valley Hospital. And so when I was 14, I started volunteering at Credit Valley in the cancer center. And so this was really like my first experience actually interacting with cancer patients and, kind of seeing the toll that cancer therapies can have on patients undergoing treatment. So waking up at 4 a.m. for all of high school eventually paid off, and I got a full athletic scholarship for rowing to Eastern Michigan University for my undergrad degree. So when I got to Eastern, I was like really in my element. I would wake up very early every day and row. I would have second practices in the afternoon, and I would run to chemistry labs sometime in between in my sweats. And I also reached out to the American Cancer Society and began volunteering at a cancer center that was just off of campus. At the same time, I got my rowing team involved in events through the American Cancer Society, like the Walk for Breast Cancer and other fundraising events as well. So my final year, my undergrad kind of just flew by in a blur. I was so busy with classes and rowing and all of my labs that I really couldn't find my footing, let alone find time to write the MCAT. So even in the summers when I was back home from university, I think I would spend upwards of 60 or 70 hours a week at my rowing club between coaching Paralympians, running a kids' day camp, and just doing a million other things that I couldn't bring myself to say no to. So when I graduated from my bachelor's and found myself jobless, I decided to move back to Toronto and take a job as a clinical assistant for an orthopedic surgeon. So even though I was really hoping to go into oncology and I knew that I wanted to become a medical oncologist, ultimately, I hadn't written the MCAT or applied to any med school. So I thought that I would take this clinical position and, make some money while I studied to write the MCAT, and I could apply to school the next year. So life was going pretty well. My boyfriend and I were living in a condo on the Toronto waterfront. I had a good job. I was working out all the time, twice a day, most days. And I was planning to write the MCAT sometime that fall so that I could apply to med school for the following year. But one night, as I was sitting in bed and scrolling through my phone, I reached across my chest and felt a lump in my breast. And I stopped, sure that I was obviously imagining things, and checked again. And there was a very definite lump. So I don't have any family history of breast cancer, but I had really, for no reason that I can explain, gotten into the habit of doing regular self breast exams. And I had definitely never felt anything like this before. The words breast cancer like instantly popped into my head. And I remember sitting bolt upright in bed and just really like not knowing what to do. So the rest of that night, somehow, I got through it. And in the morning, I woke up and drove straight to my family doctor's office. And I had a really great family doctor, but even having a great family doctor, he told me that I was too young to have breast cancer, as many people would tell me, and that it was surely nothing. And his opinion was that we should just leave it. And, I should come back in maybe 3 to 6 months and he can check it again. And I told him no, that seemed like totally ludicrous to me. And I told him that I wasn't leaving his office without an ultrasound requisition. So he gave me a requisition. I took it to the hospital where I was working and I asked them to do an ultrasound on me. And I remember as I was laying on the table and I had this like nice female ultrasound tech, telling me again that I was too young to have breast cancer and that women come in all the time with lumps and bumps and it's never anything. And then she suddenly just put down the wand and left the room without saying anything to me. And she came back a couple minutes later with the radiologist by her side. And he picked up the wand and began examining me himself. And then he somberly put it down, slowly turned to me and told me that he strongly recommends I come back for a biopsy and that I should do it as soon as possible. And I remember picking up my things, getting dressed, and just like walking like a zombie out to my car. And for the first time since I had found the lump, I started just like sobbing really hard, because in that moment, I really knew like what I was actually dealing with. But it still really didn't make any sense. I was so healthy. I was in such good shape. I ran, I cycled, I worked out every day, twice a day. I felt totally invincible. But no matter how many people told me that I was too young to have breast cancer, on July 23rd, 2011, at the age of 23, and just 5 days after I found the first lump, my life was forever changed when I was diagnosed with invasive ductal carcinoma in the right breast. And with no family history and really no risk factors, it obviously was a bit of a shocking diagnosis to anyone and everyone who heard it. But family history and risk factors aside, what was probably even more shocking was how healthy I was. I looked like someone who was capable of running a marathon, and I was. I had spent so many years volunteering in the cancer center, and I always imagined that one day I would find myself transitioning from volunteer to doctor, but I really never considered the possibility that I could wind up a patient there myself. So pathology showed that my tumor was stage 2 triple negative. And so I was given a really aggressive treatment regimen. I had surgery, 8 rounds of dose-dense chemo, and 33 radiation treatments, all of which were ironically enough done at the very same cancer center that I had been volunteering in for many years. And when I finished treatment, so much in my life had changed for me. I went from being in a long-term relationship to being single, from being in peak athletic form to barely being able to climb a flight of stairs without getting winded. And most importantly, I went from being totally blissfully ignorant to the rawness of cancer to being wholeheartedly aware. And while to most people that sounds pretty awful, it really, for me, was a blessing in disguise. Cancer really opened my eyes and has changed my life in ways that I never could have imagined. So having missed the MCAT because it was scheduled mid-chemo, I was still obviously in no place to go to med school. But after being through treatments and being through cancer firsthand, I really just didn't want to go back to the world of orthopedics anymore. I wanted to work in oncology and I wanted to work in it right away. So I decided to go back to school and get into cancer research. So less than 6 months after I finished my treatments, I moved to Hamilton, bought my first house, and started my master's degree in chemical biology at McMaster University. So for my master's degree, like Kathy mentioned, I really worked on developing new molecular imaging probes So this was really looking at developing things to help us diagnose cancer better and earlier. And my work was specifically focused on breast cancer. After I finished my master's degree, I again really wasn't sure what I wanted to do, but I wanted to stay in cancer research. I had spent a couple of years really focused on diagnosis and really wanted to switch over and look at what therapies were being developed for breast cancer use. And so I came back to McMaster to do my PhD, this time in the Department of Biochemistry, working under Karen Mossman, and I wanted to study new and improved therapies for breast cancer. So in the last, decade that I've been working in cancer research, and really I've always had a focus in breast cancer, I can tell you that breast cancer research has come leaps and bounds in the last, 30 to 40 years. We have better diagnosis, we have better preventative measures, we have much better therapies. But even with all of these improvements and all of the milestones we've hit with cancer research, we still have a huge burden when it comes to the cancer burden in the population, and specifically for breast cancer. So it's estimated that 1 in 8 women will develop breast cancer in their lifetime. And current treatments for breast cancer, as I'm sure most of you are aware, really are a combination of many different modalities. So most patients will receive surgery, chemo, radiation, hormonal therapy. We're just kind of throwing everything at them. And unfortunately, a lot of these standard therapies are hugely invasive, and they also come with a laundry list of short and long-term toxicities and side effects that patients have to deal with. So one of the things that I've always been really focused on in my research is how can we treat breast cancer better, and how can we offer patients an enhanced quality of life during and after treatment? And that's where the immune system comes into play. So I'm sure everybody's heard the word immunotherapy, and we've been dubbed in the scientific community as being in the era of immunotherapy. And really, when we talk about immunotherapy, we're talking about many different types of therapies, but really they all share this common principle of boosting the patient's immune system to fight the cancer cells within them. So instead of delivering these highly cytotoxic therapies that are kind of just ablating any rapidly dividing cells, like your cancer cells and your hair cells and your nail cells, we're switching gears and we're trying to boost your immune system to do that fighting for us. And initial trials and therapies that have come down the pipeline for immunotherapies have really proven to be most effective in cancers that are characterized by high rates of cell turnover and high mutational load, cancers that we would characterize as being highly immunogenic. And those are typically cancers like non-small cell lung cancer and melanoma. But now we are seeing that there are so many clinical trials emerging for a broad spectrum of disease. And indeed, there are many immunotherapy clinical trials coming out that include different subtypes of breast cancer as well. So in order to have any sort of comprehension of immunotherapy, you really need to have a base understanding of tumor immunology and of the immune system. And this one slide and looking at all of these different things could definitely be a webinar in itself. So we're only going to scratch the surface, but tumor immunology is a very complex process. And it's something that, with decades of research, we've only begun to understand. And we've just begun to understand it enough to be able to manipulate the immune system to develop these immunotherapies. But as we are testing them in patients, we are constantly getting more information and understanding more the complexities of the immune system and how it interacts with cancer. So just a couple things to draw your eyes to in this picture. We have so many different types of immune cells in our body, and they all have slightly different functions. And even immune cells that have one function, they can actually have more than one, and they can function in different ways. So one that people will often be familiar with is this green guy over here. This is a Cd8 Cytotoxic T Cell. So typically when we think about the immune system and we think about the immune cells killing our cancer, we're talking about Cd8 cytotoxic T cells. So there are other types of T cells. So we often broadly hear people just say the T cells, but really it's these green guys that are the cytotoxic killers that can actually kill tumor cells. And then over here, this guy with all of these Ys all over him, those Ys are actually antibodies. And so this is a B cell. And B cells, again, have many different subtypes. So it's really generic when we just say B cell. But B cells really recognize specific things that are excreted from the tumor. So tumors make something called antigens. It's just like a protein that the tumor is secreting into the body. And B cells can recognize this antigen and make antibodies against it. It's like when we think about COVID, and we talk about COVID, of course, all the time now, the COVID virus is actually secreting antigens that B cells make antibodies against. So when you're driving that response, that immune response to recognize and clear something from the body, that's largely driven by B cells. But while we often think about immune cells as being able to kill and clear bad pathogens from our body, they actually can also have pro-tumorigenic effects as well. So there are also immune cells like this regulatory T cell up here, or this myeloid-derived suppressor cell down here, that can actually secrete bad things in the body. And that in the case of cancer, they can actually promote cancer. So these immune cells can actually function to, make tumor cells grow more, to make them proliferate outside of the boundaries of the primary tumor and potentially reach metastasis as well. And so again, this is a very complex environment when we talk about all of these different immune cells interacting with one another. And this tumor immunology is something we aim to understand better so that we can learn how to manipulate it to clear tumors instead of driving their growth. So when I talk about those dual and opposing roles, where you have immune cells that are functioning to clear cancer, and you also have immune cells that are functioning to drive cancer progression, this is a theory that we have in the field called cancer immunoediting. So cancer immunoediting, you don't need to worry about the specifics of this figure other than to understand this is a very foundational concept in the field of cancer immunotherapy, and we call it the 3 E's. So elimination, equilibrium, and escape. So the theory states that in our body, there is always rogue cells that are trying to essentially become tumors and trying to become cancer. But the immune system is very good during this initial step of cancer initiation of recognizing these mutated cells, signaling them for destruction, and they're killed long before a tumor ever forms. But of course, occasionally, these cells go undetected by the immune system and they can form a cancer. Again, once we have that cancer formed, again, some of those cancers can still be recognized and eliminated by the immune system, or we can have them go into a dormant state, where they're essentially still there, but they're just in dormancy. And when we have tumor escape, these are cells that have fully evaded immune recognition. So the immune system cannot see them. They look just like normal cells to the immune system. So they're not signaled for destruction. And that's when we get a full-blown malignant state. So you can have a full-blown tumor growing up. So there's always this kind of constant push and pull in cancer immunoediting, where we really theorize, and it's been shown that the immune system can actually provide anti-tumor immunity, where we're clearing tumors, but it can also drive tumor progression as well. And so for breast cancer in particular, one of the challenges with immunotherapies has been that breast cancer is typically considered to be non-immunogenic. And when I say that, what I mean is this tumor on the left here, what we call a cold tumor. This is a tumor that is really densely packed with tumor cells and doesn't have a lot of immune cells in it. So it might have a few immune cells sparsely interspersed, but it doesn't have a lot of immune cells infiltrated through the tumor. And so if we treat this cold tumor with immunotherapies, there's not a lot of immune cells there for us to manipulate and use to try to clear that tumor. And so there's a big focus in the field on how can we take these cold tumors, like most breast tumors, and make them hot tumors so that they're infiltrated with all of these different immune cells so that they will respond to immunotherapies. And one of the ways that we do that is actually by taking standard therapies like chemotherapy and administering just low doses of them to really increase the inflammation to just bring immune cells to the tumor. So we don't actually care if they do anything. We're just using the chemo to just make this an inflammatory site and bring all of these immune cells, and then we can treat with immunotherapy. So when I talk about tumor immunogenicity, this is a pretty famous graph in the field where these researchers looked at many different markers for immunotherapies across a wide spectrum of cancers. And it's obviously difficult to see all of the different names, but basically the ones that are on the right are considered to be more immunogenic. So these cancers have a higher score. So they have more immune cells and they have higher levels of these immune markers in the tumor. And so these tumors over here on the right are actually very likely to respond to immunotherapies, with this being a melanoma right here on the far right side. And breast cancer is right here in this box. And so what you can see is that breast cancer is in the lower 50th percentile of immunogenicity when it comes to cancers, but it has a very wide spread. So there are some breast cancers, typically those that are hormonal positive actually, are less immunogenic. And then something like triple negative, we can actually find some triple negative breast cancers that would be up here that have much higher levels of immune infiltrates and therefore will respond much better to immunotherapies. And the whole concept is, how do we take these ones down here below this threshold and push them up higher so that they become immunogenic tumors, so that these patients can also benefit from these really valuable new therapies that we're making. So there are many different types of immunotherapies, and we're going to kind of quickly go through all of these today. But again, I would say any one of these therapies could be a standalone webinar on its own. And so I want to start with immune checkpoint blockade, because this is probably one that most of you have heard about, and it's one that is definitely kind of flooding the clinical trial landscape for almost all cancer types, to be honest. So back in the 1990s, we had this like amazing discovery that kind of was a fluke, to be honest. And the researcher has now been awarded the Nobel Prize for it. But basically, we have a tumor cell down here at the bottom, and we have a T cell up here on the top. So remember those green guys. This is like one of those green guys from the tumor immunology slide. And so T cells have this receptor on them, PD1. So this is programmed death 1. So this is a receptor on the T cell, and the tumor cells have the mirror receptor or the ligand called PDL1, so programmed death ligand 1. And what happens is tumor cells can upregulate PDL1. So they can have lots of these PDL1 ligands on their surface that will bind to the PD1 ligand on the T cell, telling the T cell to deactivate. So it basically tells the T cell to not be active and not kill any other cells. And so this is one of the ways, this was a huge discovery in the field. And this is one of the ways that tumor cells actively shut down the immune response. So they express these PDL1 ligands and they tell T cells, don't kill me, don't kill any cells, just deactivate. And so what we do now is we take this thing that's shaped like a Y over here. This is an antibody, and this is an anti-PD1 antibody. So this antibody is administered to patients and it blocks to the PD1 site. So that doesn't tell the T cell to shut down. It just blocks it so that the PDL1 ligand can't tell it to shut down. And so there have been other checkpoints that have been discovered and that are actively being tried, like CTLA4, that also have really good results clinically. But I would venture to guess that most of you have heard about the PD1, PDL1 checkpoint, because that is definitely the most prevalent. And we see this clinically being used for many different types of cancer. So it's really not a therapy that's enhancing the immune system. Interestingly enough, it's actually just blocking the tumor cell from shutting off the immune system, really just allowing the immune system to do what it would normally do. And so this is a very large clinical trial. This is a phase 3 study that was run in triple negative breast cancer patients. And don't worry about the specifics of the graphs here, but basically patients that had triple negative breast cancer were subtyped as either being PD-L1 positive. So they either had a lot of that PD-L1 on their tumor cells, or PD-L1 negative where they didn't have a lot of it. So again, that would be a marker of immunogenicity. So if you have a lot of PD-L1, that's bad because your cancer is going to shut down the T cells, but it's good from an immunotherapy standpoint because we can know that you'll respond better. And so in this study, we treated patients with either this anti-PD-L1 antibody and chemotherapy, or with chemotherapy alone. And we saw a significant overall improvement for the survival of patients that were PD-L1 positive and treated with the double combination. So this was really like a landmark paper showing one of the first trials to show the utilization of immune checkpoint blockade in breast cancer patients. And now if you do a little search on clinicaltrials.gov for immune checkpoint blockade in breast cancer, and this is specific to Canada, there are numerous studies that come up because, like I said, we're really seeing immune checkpoint flooding the clinical trial landscape. It's being tried with a lot of standard therapies. We see it a lot for triple negative breast cancer, but we are seeing it for other types of cancer or other types of breast cancer as well. So the next therapy that I want to talk about is oncolytic viruses, which maybe you've heard about, maybe you have not. But oncolytic viruses are really interesting because they actually came from just standard clinical observations. So really, like you see this patient here on the left has a very large tumor here by his eye. And this patient actually got a natural virus. So he just got a viral infection, like a herpes virus, I believe it was. And in the course of him running the course of the viral infection, they noticed that his tumor actually disappeared. And this happened many times. So we have so many clinical documentations of this from, 50, 60 years ago even. And this really led researchers to open up to the idea that we could actually use viruses and harness them for therapeutic potential for cancer. And over time, we've also learned that not only can we take these natural viruses, but we can actually manipulate their genomic code and make them better at killing cancer as well. And so here you see an oncolytic virus, and this is one of the best things about them is that when oncolytic viruses enter a normal cell, the cell is able to pretty quickly clear them and it doesn't replicate. So we end up with just an unaffected cell. But when they enter cancer cells, they actually really rapidly replicate and it can kill not only that tumor cell, but also other neighboring cells as well. And so this is a really specific type of therapy that really provides good safety profiles and doesn't kill all of the other healthy cells around the cancer as well. And so the way that they work, there's two functions. They can either have a local effect, like I just showed, where they go into a tumor cell, they replicate, and they cause that cancer cell to burst. Or they can actually also have a systemic effect where having this virus triggers an immune response because your body naturally wants to clear viral infections. And you can get this, systemic tumor-specific immune response that can even lead to the death of distant cancer cells in the body as well. And so there's only one oncolytic virus that's currently approved by the FDA, and that's called TVEC, and that is approved as a first-line therapy for melanoma patients. It works very well in melanoma. But we also have some clinical trials ongoing for breast cancer as well. So in Canada, I could only find one that's actively recruiting right now, but there is one actively recruiting phase 1 trial for an oncolytic virus in breast cancer. And there are many more if you expand your search outside of Canada as well. So another one that maybe you've heard a bit about are cell-based therapies. So these are therapies where we really look at taking immune cells out of a patient, manipulating them in a lab to make them better at killing cancer, and then reinfusing them back into the patient. So the cells are isolated, we engineer them to either express something or engineer them or just grow them up so that there's just more of them. And then we infuse those modified cells back into the patient to kill the cancer. And one of the most prevalent right now in clinical trials, and we actually have not for breast, but we have a really large CAR T clinical trial that's initiated out of Ottawa now and is, nationwide. And, Canada is kind of catching up, I want to say, to the US on the CAR T cell therapy landscape now, which is great. So CAR T cell stands for chimeric antigen receptor T cell. So really we're looking at taking the receptor of the T cell, so the piece that would actually link it to another cell. So again, it's the same process. We acquire T cells from the patient. So you just take blood and you isolate them from the blood. Then we use them to generate these specific CAR T cells. So these are manufactured in a lab and they are cancer killing agents. We can grow them up in these little plates in the lab to make more of them. And then we infuse them back into the patient and they can attack the cancer cells, resulting in tumor killing. And again, I don't believe we have any CAR T trials ongoing for breast cancer in Canada right now, but there are many publications about CAR Ts and breast cancer. And there are so many clinical trials about CAR T for other cancers right now. And I do believe we'll see it moving into the breast space in the next couple of years. So cancer vaccines are a pretty new approach, I would say, for immunotherapies. It's definitely not as widely explored as the others, but definitely cancer vaccines, I want to say the difficulty with them is that they need to be more personalized. And so doing them on a large grade scale is more difficult. But basically, when I talked earlier about the tumor antigen, when we think about COVID as an example, COVID expresses something that we need to target with the vaccine. So just like a virus, your tumor will express something, a specific antigen. And if we can make a vaccine against that antigen, we can essentially create an immune response against that antigen and make your body clear the tumor. The problem is that not all tumors express the same antigens. In fact, they all mostly express different antigens. And even within the same patient, a patient can express one antigen and then switch and express a different antigen later on. So it's a bit of a more difficult approach, but there are definitely cancer vaccines coming down the pipeline. And I should say that when I say cancer vaccines, I'm not talking about something like the HPV vaccine where it's preventative. This is what we call an in situ vaccine. So these patients already have cancer and we're using a vaccine approach to make the immune system recognize the cancer that's already in them. And there is actually an ongoing recruiting clinical trial right now. It's just an early phase 1 for TNBC patients with a cancer vaccine in Canada. So another one that we've seen for cancer for a really long time are antibody drug conjugates. And so antibody drug conjugates were basically developed because we had some chemos that were really cytotoxic and we knew that they could kill cancer really well, but they would also essentially kill the patient if we just delivered it through an IV. And so we needed a way of delivering those cytotoxic agents specifically to the tumor so that it could kill the tumor, but spare the healthy tissue. And so that's how we developed these things called ADCs, where we take this Y-shaped thing here, which is an antibody. We use a little linker and we attach the cytotoxic agent. So there are a lot of these where this cytotoxic agent is a chemotherapy. And it's a chemotherapy that, again, would just be too toxic to deliver to a patient just through an IV on its own. And so the way that it works is it's targeted drug delivery. So that antibody binds to something that is specifically expressed on the cancer cells. So it's not going to bind anywhere else in the body. It's going to bind to the tumor, and then the rest of it is just going to be excreted from your body. When it binds to the tumor can bring it inside, can bring it inside the cancer cell and release the contents, and you'll basically have site-specific delivery of that chemo or whatever the cytotoxic agent is directly to the cancer cell, which leads to a process called apoptosis, which is just a fancy word for cell death. So this is just apoptosis happening, which is when the cancer cell ruptures and dies. And again, there are many ongoing clinical trials for antibody drug conjugates in all types of cancer, but there are quite a few for breast cancer. And so this was not an exhaustive list, but there's quite a few in Canada that are actively recruiting right now. So overall, I mean, if you do a quick PubMed search, which is really, this is the website for looking at scientific publications and manuscripts, and you'll also find clinical manuscripts detailing clinical data here as well. If you do a quick search of just breast cancer immunotherapy, right now, you find over 7,500 results. So the field of immunotherapy has definitely crossed into breast cancer big time. And, you know, it's going to take time to see these therapies become first line standard therapies, but we have huge progress, and there is so much science that's being done every day to really better understand these therapies and better understand how they can be used for breast cancer patients. And additionally, if you look at immunotherapy in breast cancer on clinicaltrials.gov, you also find more than 300 clinical trials that are ongoing for immunotherapy in breast cancer right now, which is really great because we're really starting to see, like I said, those immunotherapies crossing into not only you know, those highly immunogenic cancers, but also crossing into those more cold tumors as well, where we're seeing them combined with other therapies like chemotherapy usually. And so, you know, I'm asked kind of like all the time if it's weird researching and studying a disease that I've also had as a patient. And I would be lying if I said that it's never weird or never difficult to read paper after paper about the poor prognostic outcomes of triple negative breast cancer patients and the high rates of recurrence. But as difficult as that sometimes is, I can also tell you how like weirdly wonderful it is and how fortunate I am to be able to be a volunteer, a patient, a researcher, an advocate, and to really just know cancer so incredibly intimately and to now willingly allow it to infiltrate every single aspect of every day of my life. And I would say that patients are really inherently biased towards translational cancer, of course, progress that you can really measure in months or years of prolonged overall survival. And on the flip side, scientists tend to be inherently biased towards more basic research. They really want to understand the how and why of how something actually works and really the nitty mechanistic details. And I feel very lucky every day that I have these dual and really not opposing opinions, both within my own head, and that I'm able to really see both sides of the puzzle. So I really never lose sight of the bigger picture. Cancer honestly has really like thrown me a lifeline. It's taught me to be present in my everyday life, to enjoy nature, to explore, to travel, and to honestly love my children so much that I could probably explode just looking at them. So cancer really does not discriminate. It doesn't care if you're rich or poor, male or female, young or old. And honestly, this is really what makes it such a challenge to study and such a challenge to continue to develop new therapies against. It really doesn't care about the statistics. And while we really should use the statistics as guidelines, they really should be just that. My own diagnosis fell hugely outside of the statistics. And if I had allowed it to push me to be brushed off the way I initially was, because the odds were heavily swayed in the other direction, I probably would have found myself in a much more grim position when I finally received a complete diagnosis. So thank you all for listening. I'm happy to take any questions if you want to pop them into the chat or the Q&A. Just some suggested reading. If you have not read The Emperor of All Maladies, it's basically the encyclopedia on the field of oncology. It's so eloquently written. It's massive and a huge undertaking to read, but I strongly recommend it. It is one of the greatest books written. There's also a newer book called The Breakthrough: Immunotherapy and the Race to Cure Cancer that I recently finished. It's also a really excellent book detailing some of the milestone findings for immunotherapies and the development of this field. And there's also another book called Immune. It's a little bit more of like a textbook about the immune system, but in lay language and helping to really understand the complexity of the immune system. And feel free to reach out to me via email. My email is there at the bottom if you have any other questions. And otherwise, I think I'll turn it back to Jen and Kathy for question time.
First of all, Alyssa, let me tell you, that was an excellent presentation. And I really want to tell you how much I appreciate, and I'm sure the audience appreciates the pre-presentation of what your journey and your experience was that led you down this path. And I think I can speak for many in the audience that may have had that same passage, learning about finding a tumor, not understanding what's going on, or understanding what's going on. And also you bring in the element of advocating for yourself when a doctor would have said to you, you know what, you're too young. Often we hear that. And that also tells us that we need to take ownership of our instincts, because basically it's your basic instincts that tell you, no, my alarm just went off. I need to pursue it. I really want to, to do it my way and not just listen. So I really appreciate that experience. I don't want to call it a story, your experience, your life experience with the, experienced breast cancer. There are a lot of questions that came in that I'd like to get you to answer some of them. And like you said, people can just email you with other questions that we will not be able to get to. So I'll start with question number 1. If immunotherapy boosts the patient's immune system, what happens to patients who have an autoimmune illness like MS? Like this patient has both MS and breast cancer.
Yeah, I think, autoimmune disease is going to be a large exclusion criteria, unfortunately, for most immunotherapies. So there will be some immunotherapies that patients with an autoimmune disease will qualify for. But like I said, tumor immunology is a very complex field, and autoimmunity is equally complex. And I think we are just starting to scratch the surface to understand how immunotherapies can work in a cancer setting. And when you throw autoimmunity into there, there's a lot of other considerations. So you would have to be working with probably a specialized oncologist and a doctor who's working on autoimmunity. So unfortunately, I think that's going to be more of like a case-by-case basis. And most patients with an autoimmune disease pre-existing would be excluded from the current clinical trials.
Yeah. So I have a question number 2. If my tumor has already been removed, does this mean that immunotherapy is not something that I can consider?
No, that's a great question. Definitely not. So I realize everything I showed today was in the context of a solid tumor, but definitely immunotherapies are used for even like micro metastases that, we can't even really image. And immunotherapies, the whole concept is really driving a systemic immune response. So while you might not benefit from certain therapies that really target that solid tumor microenvironment, immunotherapy in general can still be used after surgical resection.
Right. I have question number 3. Are HER2 tumors immunogenic?
I would say there's a spectrum of immunogenicity for HER2 positive tumors. A lot of patients that have HER2 disease already have a lot of targeted therapies. And so we haven't seen them being as widely put to the forefront of clinical trials for immunotherapy. But that being said, we're now seeing a lot of, those antibody drug conjugates and things like that targeting HER2 breast cancers, because HER2 itself is a really good target, and we know that it's really specifically expressed on those patients' cancers. So it actually makes it a little bit easier to navigate how we can target those tumors with immunotherapy.
Okay. I have another question that just came in. What are your thoughts on immunotherapy possibly being used in the future to prevent cancer? Is this a possibility? So is this something that will be used in the setting of preventing cancer? Are there any studies in that way, or is it specifically used as a treatment?
So right now, immunotherapy is used for therapy. It's not for preventative measures at all. That being said, there is a large portion of the field that is studying pre-malignant niches. So trying to look at the cells that will become cancer cells. And there is a lot of progress being done on how to identify those populations of cells and then treat them. So I would say we are still in the stage of how do we identify those cells properly, and we are not yet in the stage of how do we treat those pre-malignant cells. But it is possible that in the future we will be able to identify, in your breast, these cells that are going to become cancer at some point in your life. And so, yes, we can treat them now with the immune system. But that's definitely still like a few years away, I would say.
Okay, great. This question, how does a patient find out if they would be a good candidate for immunotherapy? Is this possible if they have already completed surgery, radiation, chemo? So I guess they're asking if they've gone down that route, what could they be, candidates for immunotherapy after all that?
Yeah, so there's two different types of trials. We'll have clinical trials that are really for like early stage disease, where they will really want patients that haven't had any other therapy. But there's also always therapies that are for later stage patients as well that have exhausted their first line therapies. So if you want to know if you can actually qualify for a trial, there's a couple ways you can do that. You can go to clinicaltrials.gov or Clinical Trials Ontario website, and you can just look them up yourself and start there. But you should also just ask your oncologist, and your oncologist, if they seem reluctant, then you should push and tell them that you want to know about clinical trials. So if they themselves are not involved in immunotherapy clinical trials, they can direct you to somebody else who is.
Okay, and in that same line of questioning, so is immunotherapy really just for triple negative breast cancer?
No, definitely not. We see a lot, like I said, there's a lot of ADCs for HER2 right now. I would say the reason why out of breast cancer, triple negative has come as kind of the first one for immunotherapy is because out of all of the subtypes, it is the most immunogenic. So these patients are the most likely to respond to immunotherapy, but it also has the worst prognosis and very limited targeted therapies right now. So we know that if a patient overexpresses the estrogen receptor or the progesterone receptor, we can give them these hormone modulating therapies that are very safe and very effective and work very well. But if a patient has triple negative, we don't have a specific target to go after. So clinically, we're just like ablating them with high dose chemo and tons of radiation and like all of these aggressive treatments. So triple negative is just a really good candidate for immunotherapy because these patients need better therapeutic options, and they actually have higher levels of immune markers in their tumor as it is. So we've seen a lot of the initial clinical trials being in TNBC, but definitely there's other trials across the spectrum of breast cancer.
Great. Are there specific nutrients that should not be used with immunotherapy? Example, anything that affects PD-L1?
I don't know of any nutrients that affect PD-L1. There are definitely like naturally occurring viral infections and stuff that can upregulate PD-L1. I don't think we know yet how COVID modulates it, but there definitely are naturally occurring kind of carcinogens that will change your PD-L1 levels. But I'm not aware of any nutrients specifically that would change that or that would be an adverse indication for immunotherapy.
Okay, and along this same type of question, what are some of the side effects of immunotherapy? So if you just give us a little overview of
yeah, that's a great question. So oncolytic viruses have very mild side effects. If anything, people might experience what seems like a mild viral infection. So, a cough and cold and normal symptoms, a mild fever. Immune checkpoint inhibitors in most patients are well tolerated, but when they were initially discovered, we did have a lot of patients having what we call cytokine syndrome, where essentially, and this is something that happens a lot with cell-based therapies as well. So essentially we're unleashing the immune system to kill your tumor. And sometimes what can happen is the immune system gets hyperreactive. And so the immune system is really like attacking your body. and patients can experience really extreme fevers and nausea from that. It's all been pretty well clinically managed, and it's something that we're not seeing as much now in clinical trials, but definitely in the earlier days of immunotherapy, we saw a lot more of that, and we just didn't really understand it.
I think I'm going to go with one that might take a little bit of time for you to answer, and probably what might be the last one. And I think this might be a good way to close the segment. How does a patient find out if they would be a good candidate for immunotherapy? Is it possible? Is this possible if they have already complete? Oh, wait a minute. No, I asked you that question already.
But that's okay.
Yeah, I think we went through that question. Jen, did we go through that one?
We did. That was a two-parter.
Yeah. Okay, that's why. Okay, sorry about that.
Okay.
I'm gonna go with, is immunotherapy in clinical trials now, or is it available to anyone with breast cancer? How do you have that discussion with the oncologist, basically?
Yeah, so it's not, immunotherapy is not approved by the Canadian regulatory authorities as a standard therapy for breast cancer right now. But we are seeing particular checkpoint antibodies being approved in combination for select instances. So it's not approved as like an overarching standard therapy. But so if someone is diagnosed with breast cancer and they feel that they are a candidate and they want to know if they're a candidate for immunotherapies, they should first ask their medical oncologist about that. That is something that a medical oncologist would be the one to speak to about. And like I said, if their medical oncologist seems hesitant or unwilling to, have an open discussion about immunotherapy with them, they should ask their medical oncologist to refer them to the correct person. Usually, if you look up a clinical trial online, you can see a list of all of the sites where the trial is being run. And you can also see a name of the study director or the principal investigator who's running the trial at those sites. And there's always an email there. So you can even directly reach out to the study director or the investigator and tell them that you're a patient and you want more information about the trial. And usually they are able to direct you to the proper doctors who could actually help facilitate getting you on trial if you actually are in the inclusion criteria for it.
Great. Thanks, Jen, for sending all those questions. But I'm going to slip this one in and then close off. Can immunotherapy be used in conjunction with hormonal therapy?
Yeah, it can. So they have different mechanisms of action. They don't work the same way. I would say that we do see some patients being treated with immunotherapy and like HER2 therapies right now. There probably is less of a need for immunotherapy in conjunction with hormonal therapy. So usually if someone is responding well to hormonal therapy, they don't have a need for another type of therapy. It would be when they stop responding to that hormonal therapy that they would really need a new therapeutic avenue. So usually they probably wouldn't be given in conjunction, but there's no clinical reason why they couldn't be.
Okay, that's great. That's great. So there are a lot of other questions that I think you will be asked personally. Again, I cannot tell you how wonderful the presentation was, and the combination of your story and your work really made it, a well-rounded presentation. Jen, before I sign off with the closing remarks, do you have anything that you want to add at this point?
I don't. I think that was an incredible presentation. And like Kathy said, and so many participants said as well, thank you for sharing your story sort of at the beginning of it and really how this applies to you and your unique experience. And then also translating so much knowledge, I think, into a way that most of us can understand. So a lot of great comments coming in through the chat, echoing that appreciation. So thank you so much, Dr. Vito.
So that's it. That's our time for today. Thank you, everyone, for your questions. They were great questions, and for joining us. Thank you, Dr. Vito, for this informative and excellent discussion. As you know, Thank you again to our sponsors, Viatris, Novartis, Merck, AstraZeneca, and Pfizer, who made this session possible. Thank you everyone for joining us. We look forward to connecting in another virtual session in the future. And I'm sure we'll have other sessions with Dr. Vito. I really, once again, want to thank you for a remarkable presentation. Thank you, Jen. Thank you, everyone. Have a great day.